ClinHaem Haematology Demystified.
So, hi everyone, welcome back to ClinHaem. This is Usman again, and today I'll be taking you through the practical aspects of hematopoiesis. Hematopoiesis being the process by which our body makes new blood cells. So specifically the stem cells, hematopoietic stem cells, how they divide and differentiate to make more functioning blood cells. And as the name suggests, I'll be focusing mainly on the clinical aspects of hematopoiesis that are relevant for day-to-day work. This will be the layout of the talk today. So before we go into hematopoiesis, I just want to ask you a question. Do you believe in miracles? Now, if he was someone like The Rock giving you this talk, he would probably say something like this, and which we all can agree is quite rude. So you're in luck. It's not The Rock who's going to do hematology. He's better off doing wrestling and Hollywood or whatever. And I will try to convince you towards the end of the talk that the miracle that I'm talking about is the miracle of hematopoiesis. So every second, around 2 million to 3 million blood cells are born, trained, and shipped into the circulation. Now, that's quite a miracle, isn't it? Can you guess, especially for the mathematicians out there, can you let us know how many cells you would have made just after this very short video, you see? The site of the miracle is the bone marrow, which is the inside of the bones. And in infants, they are even more miraculous. They can make blood cells in all their bones. In adults, it's restricted to vertebra, ribs, sternum, skull, sacrum, and pelvis, and so basically the axial skeleton and the proximal ends of femur. And in children, there's a transition from infants to adults, and depends on how old they are to see which bone might be producing, um, which bone marrow might be the site for hematopoiesis for that particular age. So this takes us to the first clinical. Actually, before that, if you were still stuck on the rock thing, I actually got a medical student go up to the ring and just give him a strong word of caution to not to repeat that again. Of course, metaphorically in an AI word. You all know what would happen to him in the real world, because the comparison is quite obvious there. Anyhow. So it takes us to the first ClinHaem Pearl, which is an abnormality called extramedullary hematopoiesis. So as the name suggests, in this process, the hematopoiesis is happening outside of the medullary cavity, outside of its normal site for that age. So for a classic example is myelofibrosis, which is a condition where because of fibrosis in the bone marrow, as the name suggests, the stem cells are pushed out of the marrow and they start to home into other organs, like especially the spleen, and they start replicating there in the spleen, and that gives rise to a massive splenomegaly, which can actually reach, from the left side of the abdomen, it can reach into the right iliac fossa. That's how massive it can be. Now going on to hematopoiesis itself, it's important to know what a stem cell is. This is a concept that's very important, and it took me quite some time to grasp it as well. But it's actually quite simple. Stem cell is basically a cell with two qualities. It's totipotent or multipotent, by which I mean that it can either give rise to all the tissues in all the cells in that tissue, or at least many cells in the tissue. So totipotent, all the cells, multipotent, many cells. So hematopoietic stem cell is, of course, depending on which one it could be totipotent because it can give rise to all the blood cells or that are there, and multipotent might be able to give rise to at least some of them. And the second most important quality is self-renewal by asymmetric cell division. This means that whenever a stem cell is dividing, so this is a stem cell, whenever it's dividing, one of the cell would of course be the cell that would go on to become to differentiate to become a bit more mature cell, but the other cell in the division would actually be itself. So that's how it basically conserves its own pool. So when a stem cell divides, say if it divides into two cells, one of them would be the new cell that goes down towards the path of becoming a mature cell, but the other cell would actually be a copy of itself. That's how it conserves its own pool. Otherwise, if the stem cells kept replicating, after a time, they would, you would lose all the stem cells, and then you won't be able to make more cells. So that's the definition of a stem cell. Um, in our blood, actually, there are in our body, actually, there are not a lot of stem cells. There's only measured in thousands. But imagine those thousands giving rise to millions or billions and trillions of cells every second or and every day. But that's how they conserve them. And not all the stem cells are actually actively dividing. Most of them actually do not do anything, do not go into division phase. So now coming to hematopoiesis, the main deal. So I've just simplified it here quite a bit, but basically a pluripotent stem cell, hematopoietic stem cell, would differentiate into a lymphoid stem cell and a myeloid stem cell, right? And of course, it will another copy would be its own self. So when it's dividing, I've not shown that here, it would divide into its own self as well to keep its pool. But anyhow, it divides into a myeloid stem cell and a lymphoid stem cell. Lymphoid stem cell will ultimately divide and differentiate to become more to become lymphoid cells, which, as we know, are B lymphocytes, T lymphocytes, and natural killer cell is actually another lymphoid cell. So B and T cell are part of the adaptive immunity. Natural killer cell is also a lymphoid cell, is part of the innate immunity. Now, these are the lymphoid cells. So myeloid stem cell actually gives rise to all the other cells. So it will give rise to platelets, to red cells, to the granulocytes, which are basophil, neutrophil, eosinophils, and also to the monocytes. So all of these cells are called myeloid stem cells. Monocytes, when they go out of the blood into the tissues, they become macrophages. Now, just to highlight this point again, all of these cells are called myeloid cells. They're belonging to the myeloid lineage, and these cells are the lymphoid cells. Okay. Now, this is important because coming to the next clinical heme pearl, uh, uh, first of all, I want to define what a malignancy is. I'm sure we all know malignancy at its very core means that there's a cell or a tissue that's dividing without its need to do so. So, like a growth or a over uncontrolled replication, basically, without there being a need to do so. And hematological, of course, means of the one of these cells. Now, this is leukemia versus lymphoma. I've got a few slides on this, but this is really important because many people, when they are starting their journey, they do get confused about what both, these terms actually mean. And I try to simplify it here, but I'd like to hear from you if you still feel you need more clarification, but hopefully it will help. So in leukemia, any nucleated blood cell can become malignant, and the leukemic cells will be circulating in the blood. Yeah. So they originate usually from the bone marrow, but they will definitely be circulating in the blood in most of the cases. Okay. As opposed to lymphoma, by definition, as the name suggests, lymph means lymphoid cells. So it's a malignancy only of the lymphoid cells. And what the presentation would be, as the name suggests, oma means mass. So it would present in the form of a mass, like a lymph node mass or an extranodal mass somewhere else in any other organ. So leukemia, usually in the malignant cells in leukemia, they would be flowing in the blood. In lymphoma and in leukemia could be any nucleated blood cell, but in lymphoma it would be the lymphoid cells that become malignant, and they present as a mass, as the name suggests. Okay, so that's the key, like, core difference. Of course, there would be, if you go into more detail, there would be an overlap. Some leukemias can go into the lymph nodes, for example, and cause a mass as well. And lymphomas, on the other hand, can have a quote unquote leukemic phase in which the lymphoma cancer cells will start for circulating in the blood. But at its core, that's how they two are defined. And then there's another term, aggressive versus indolent hematological malignancy. Now, as the name suggests, aggressive would show symptoms quite acutely. A patient would become unwell with symptoms over weeks. And in indolent, a person can have those symptoms for months and months and months. And, they are like a chronic illness, basically. And if a patient, if a cancer would become, uh, be aggressive or indolent, it actually depends on the maturity of the cell that has become cancerous, and the type of mutation that drives the cancer. So by the maturity, I mean if the cell is immature, like a stem cell or a precursor cell, they have got more potential to divide. Yeah, so they've got that, more, you can think of it like that. They're more prone to become, they have dividing is natural to them. This is what they do: divide, divide, divide. So if they become cancerous, then they can divide a lot more than, say, a mature neutrophil who doesn't divide all the time. Now, um so that's why if the precursor cells become cancerous, they're usually present in aggressive fashion. Whereas if a mature cell becomes cancerous, it usually presents as an indolent cancer. And the type of mutation, of course, varies, is very important as well. And that's specific to each cancer. And that's we can discuss when we're discussing individual lymphomas or leukemias in the future sessions. Now, just to home that point again, so leukemia can be from any of the blood cells that I've shown in this picture that are nucleated. So of course, red cells and platelets don't have a nucleus. So practically any other cell can give you a leukemia. So for example, uh, uh, um, if the myeloid stem cell becomes cancerous, that would become myeloid leukemia. If a lymphoid stem cell becomes cancerous, that will become lymphoid leukemia. So if it becomes cancerous and floats in the blood, you know, so the cancer cells, that's called myeloid leukemia if it's a myeloid, lymphoid if it's in the lymphoid. And even here, say in natural killer cells, for example, they can have a cancer cells flowing in the blood. So that's called natural killer cell or large granular lymphocyte leukemia. So again, um, but for lymphomas, only the lymphoid cells are by definition going to become cancerous, and most commonly they will become, as I say, present in the form of a mass, and these are the lymphoid cells, of course. Now, uh, as I say, aggressive versus indolent. So when we are talking about leukemias, aggressive leukemias are called acute leukemias, and chronic and indolent leukemias are called chronic leukemias. Yeah, so that's important terminology. For example, all of the shaded area, if that becomes cancerous and the cancer cells spill in the blood, so that's leukemia. Because they are immature cells, they're likely to become acute leukemia. So acute myeloid leukemia, this is again acute megakaryoblast leukemia, acute myeloblastic leukemia, monoblastic. This all territory is acute myeloid leukemia, and depends, further subtype depends on, at least by morphology, depends on which cell they are, specifically. And if this cell becomes, one of these two becomes a leukemic, then that's called, that will be aggressive again as well because these are immature cells. That's acute lymphoblastic leukemia. Now, the problem with leukemias is not just that they're just replicating a lot more than what is required, but actually there's a block in differentiation. So say if a myeloid stem cell becomes cancerous, it will make a lot more copies of its own, but it's not functional enough to actually go become mature cells. So it will, so two problems: it will continue to replicate and make more copies of itself. So the bone marrow would be filled with myeloid stem cells. But it's actually not differentiating to become mature, say, neutrophils or red cells and platelets. So patient would be anemic or have low neutrophil counts and low platelet count because it's not maturing normally. So just replicating and not maturing. So that's the problem. Example of chronic leukemia, B lymphocyte very commonly gives you BCLL. Yeah, it's chronic lymphocytic leukemia. So because it's a mature cell and the type of mutation is such that it actually is quite indolent, a patient has CLL for ages and years, and many of them actually don't require treatment. You can just monitor them. Um, So that's the basic difference between aggressive and indolent leukemias, in terminology sense. The same thing, aggressive versus indolent in terms of lymphoma. Aggressive lymphomas are called high grade lymphomas. Yes. And non indolent are called low grade lymphomas. So for lymphomas, we're only looking at this side. So for example, as we know, B lymphocyte, even though it's a mature cell, it has many steps of maturation that happen in the lymph node. Some are precursor, some are a bit more mature. So if it happens in a precursor cell in the lymph node, then it tends, and the type of mutation is such that it makes it replicate more. It tends to present aggressively like a lymph node mass that happens within few weeks or so, and is rapidly growing, etc. But if the say a relatively mature cell and the type of mutation is such that it actually just makes it make more copies of itself, but it's quite slow process, then it would present in the form of an indolent lymphoma. So say a lymph gland swelling would be present for months and years, etc. Now, this is the summary of what I've said. So in leukemia, the clonal cell can be any nucleated cell, blood cell. In lymphoma, it's lymphoid only, B cell, T cell, reticular cell. Malignant cells in the blood would be seen in leukemia by definition in most of them, but in lymphoma, usually not, unless very rarely they can spill into the blood. Clinical presentation, because leukemia usually happens, it causes problems in, so the cancer cells usually do live in the bone marrow, so they prevent, they're not doing their own job, like differentiating into, if they're immature, differentiating into mature cells, but also don't let the normal hematopoietic stem cells do their job. And they usually cause cytopenias, so like anemia, thrombocytopenia, and low white cell counts, with the resultant complications like for anemia, shortness of breath, dizziness, etc. Low platelets would cause bleeding, and low white cell would cause infection, etc. Now, if they are, again, lymphoma usually presents in the form of a mass, and they can be annoying, but not more than annoying, they can cause organ compromise. So say if it happens around the kidneys, it can cause hydronephrosis, which is blockage of the kidneys outflow, and can cause massive kidney failure. Blood film would show abnormal cells in most leukemias. In lymphomas, usually, bone marrow is the primary site in leukemia, so it would be involved. In lymphomas, of course, you can have bone marrow involvement, but usually secondary. But it's not always the case. As I say, all of these things that I've mentioned are like general broad principles, but there's a significant overlap when you actually go into the detail of it. But this is good to get your mind around when you're actually starting with these terms. Aggressive disease in a leukemia is called acute leukemia, for example, AML or ALL. And in lymphoma, it's called high grade lymphoma. So most Hodgkin lymphomas are high grade, and the other class is non Hodgkin lymphoma. So some non Hodgkin lymphomas, for example, DLBCL, are high grade. Indolent disease is called chronic leukemia. Oh, I miss a U there. And a low grade is called low grade. And for example, CML, chronic myeloid leukemia or chronic lymphoid leukemia. And low grade lymphoma is some non-Hodgkin lymphomas. For example, follicular lymphoma is a classic example of indolent low grade lymphoma. Yeah, good. So now briefly coming to the growth factors required for hematopoiesis. I've just mentioned the most clinically relevant ones. There are lots of other growth factors and chemokines and interleukins that are present in the bone marrow that we don't need to to know about at the moment, unless we are doing a PhD in one of them. So GCSF is granulocyte colony stimulating factor. So as the name suggests, it's going to stimulate the precursors of the granulocytes, which is this one here. But it also can stimulate this one here as well. So when GCSF acts by making the bone marrow produce, making the bone marrow make more of these. Yeah. What we're especially interested in is in the neutrophil. So we give GCSF to boost somebody's neutrophil count. So GCSF is produced mainly by the bone marrow stromal cells, so the connective tissue in the bone marrow. It makes, those cells usually would give you the GCSF. This is where it comes from. Erythropoietin or EPO is mainly made in the kidneys, and this is what's going to make the bone marrow make more red cells by stimulating this red cell lineage. A bit less known, but TPO is thrombopoietin, and that's similar to EPO, but that's actually for platelets. So this will, make your bone marrow make more platelets by helping the platelet lineage. Okay, and this is predominantly made in the liver. So that's why sometimes if people have liver disease, one of the reasons for low platelets is simply that they don't have enough thrombopoietin. Okay. Now, there are lots of other hormones and nutritional requirement for a healthy bone marrow for a healthy hematopoiesis process, and that they some of which, if they're deficient, they will cause pancytopenia, like B12, folic acid, cobalt, and copper. These are usually required for making DNA for the cell, so that explains they actually called pancytopenia. So all cell lineages can be low, but some of them call predominantly anemia, like iron and androgens in males, and thyroxine deficiency can cause predominantly anemia. All of these are a topic on their own, so we will do some individual topics, individual sessions on all of them in future sessions, hopefully. So coming to the last clinical heme pearl, EPO is used in anemia. For example, EPO is used to erythropoietin analogues are given to treat anemia and conditions, for example, CKD related anemia, so chronic kidney disease related anemia, because the kidney is simply not making enough. But also use it in lots of other problems, from bone marrow problems causing anemia. We can use it in them as well. GCSF is used to reduce the duration of neutropenia post chemotherapy. So for example, for lymphoma, we give chemotherapy, and sometimes they would make them drop the neutrophil count. So we support that with CSF so that the neutrophil counts remains at a reasonable level, or at least if it remains low for a shortest duration possible, to prevent infections. And TPO is used to treat low platelets, as no surprise there, but it's only licensed in some certain conditions. For example, it's quite standard treatment now in ITP, which is immune thrombocytopenia. So that is all for now. And so in summary, you have a stem cell that differentiates into myeloid stem cell and lymphoid stem cell. Lymphoid stem cell will give you B cell, T cell, natural killer cell, and myeloid stem cell will give you all the other cells, so red cells, platelets, and granulocytes and monocytes. And they've got some important growth factors that I've mentioned that regulate them, and we can make some clinical use of them as well. And there are some other vitamins and minerals and hormones that regulate the process as well. So if you have any questions, let me know in the comments below. Otherwise, I'm also happy to take any suggestions for future topics, although we have a plan to cover, hopefully systematically cover the curriculum of hematology. Thank you.
Thank you for watching. Stay tuned for more.